we need an ideal amount of bone and supporting bone and a good gingiva covering it and the oral mucosa. So for the proper implant placement or even for a pontic placement. So till now in literature, there have been various techniques have been tried to increase the bone or to reduce the bone resorption, the amount of bone resorption followed by extraction and all. Few of them will be such as they have been done partial extraction, so that only the partial tooth will be removed to preserve the bone, and when tying implant, then they can extract and they can place the implant. And like sandwich osteotomy, like the osteotomy will be done in a sandwich method by keeping autograft and xenograft, and even forceful extrusion of the teeth to remain the bone supporting towards it. So these are the various technique. Among them, even alveolar is also technique which is more frequently followed or which is most knowingly and unknowingly we do alveolar preservation while placing an implant or during extractions. So what is alveolar ridge preservation? Alveolar ridge preservation is a procedure or a process to arrest or minimize the resorption of the alveolar ridge following tooth extraction for further prosthetic treatment, which even includes dental implant placements. So it is also known as bone maintenance or socket preservation or ridge preservation or socket grafting and even socket augmentation. These are the various terms we use in case of alveolar ridge preservation. So there are various approaches for the alveolar ridge preservation. Let's look into it. One is the socket grafts and the other is socket sealing. To be simple, socket graft is the thing where we graft it. We take a grafting material like a bone graft or any collagen material and graft the hollow the hollow space after once the teeth is removed. And or else socket sealing is we just seal it by using other concentrates like blood concentrates and all. We'll be seeing them in detail. So what is the main objective or what is our main motto and why we have to do alveolar ridge preservation? To limit the dimensional changes of the alveolar ridge following extraction, and so that we can easily place a dental implant without any need of additional bone grafting or GBR. GBR means guided bone regeneration or any other additional bone or additional substitute while placing the implant. To encourage new bone formation within the socket and to promote the tissue healing at the time of alveolar socket opening. So, and even to maintain the shape of external alveolar ridge, which plays an important role in the anterior teeth. For the once the anterior teeth are removed, you might have noticed there is severe bone resorption, especially the facial bone. So, to maintain the proper amount of the bone structure for the future teeth placement, we need to preserve the amount of bone. To be simple, alveolar ridge preservation, you can think it as a preserving the soil around the roots of the tree so that the tree will be maintained well, or once that anything happens to the plant or the tree, we can just keep another sampling in that place. So now coming to the indications. So the indications are important for the alveolar ridge preservation. It can't be done in all the cases. As we know, implant placement can be done in four types of bone types: D1, D2, D3, and D4. Same way for alveolar ridge preservation, there are certain indicators and bone types where it can be easily done and how long time it takes. Depending upon those indications, we'll get to know. First, the sites with less than 1.5 to 2 mm thick buccal plate. If we after extraction, once or before the extraction, when the teeth is compromised, if we check the buccal bone thickness on the CBCT is required. Once we check on it, when the thickness is less than 1.5 to 2 mm, then it is indicated for ARP. Or sites require bone volume to avoid anatomical structures. Like you might have be hearing sinus lift have to be done before implant placement, or indirect sinus lift or direct sinus lift, or we have to do the nerve bypass technique for the implant placements. So these have to be done in some situations, or these can be avoided by doing alveolar ridge preservation. Like the sinus membrane can be avoided by placing additional alveolar ridge or the bone graft over there, so the implant will be covered with the bone graft and other various anatomical structures can be avoided. And again, patients with high aesthetic demand like high lip line or thin biotype. See, that's the thing which I'm saying. In the anterior zone, The biotype of the patient varies a lot. The patients who have a very thin biotype and like a gummy smile patients or the high lip line patients, once the teeth are removed, there will be drastic changes or the drastic bone resorption takes place, which alters your the golden ratio of the smile. So it changes a lot. So to maintain that, we can do alveolar ridge preservation. And again, patient require multiple teeth extraction. Multiple teeth extraction means like, or at least more than three teeth in any one section. Let it be from 24 to 26 or 15 to 17. So in that cases where the multiple teeth have been extracted, there is more severe bone resorption than compared to the single teeth in those conditions. And implant placement should occur 6 to 8 week post extraction. That means second stage implant placement. Once the teeth is extracted, we keep the bone graft, we preserve the socket for the 6 to 8 weeks, and then we go for the implant placement in those cases. And when primary stability of the implant is not achieved, this is mostly encountered in the cases of bone type of D3. When we do implant placement in D3 kind of bone, when it is present, we see the primary stability is hard to achieve. In those kind of cases, we can remove the implant and do alveolar ridge preservation. Again, wait for 6 to 8 weeks and then go for the implant placement. And again, always anything comes with certain contraindications. Now let's see what are those contraindications. Acute infection cases and being extensive or severe related disease. It might be unrelated, uncontrollable diabetes, and even any cardiac diseases, or patient is on any chemotherapy or radiotherapy. In those kind of cases, and any use of any medications like medications which cause bone resorption, and even if patient is on treatment for osteoporosis, these kind of diseases, and as I told, radiation therapy, these are the cases where it is contraindicated, and we have to think and plan carefully before doing alveolar ridge preservation. Now, as I told you before, once the tooth has been extracted, what changes we see? Once the teeth has been extracted from the mouth oral cavity, so in the most of the bone resorption is seen in the first 3 months. 50% of the buccolingual width of the bone is reduced in the first 3 months, and the first bone to resorb once the tooth is extracted is the buccal side of the bone. And more prominent bone loss is seen in the facial aspect, that is the anterior teeth. Once if we observe, once the teeth is extracted, for example a 1-1 is extracted in a patient and a 3-6 is extracted, if we see the patient after 1 month, we can observe the severe bone loss in the anterior region compared to the posterior region, and rapid loss of mandibular bone in anterior region is seen than the posterior region due to the bone structure and the availability of the limited bone arch size in some patients also. And now coming to the impact of the alveolar ridge preservation on implant outcome. So basically, why we are preserving the alveolar ridge, preserving it to place an implant. So what outcomes it provides when we do it is it decreases the amount of the ridge resorption. That is what we want, so that the bone is maintained in a well contoured fashion, so that implant can be easily kept and the implant can be easily placed according to the gingival height and all, and you can give an aesthetic appearance. And apart from that, it reduces the need for further augmentation during implant placement. Like you might be seeing some cases or heard from your seniors or someone, or you might be doing some cases where while placing some implants, especially in the anteriors and even in the molars, we have to do additional bone grafting like GBR in that area. So while doing this, again, it causes a second bone resorption of the graft also happens. So in those cases, if we do ARP, this can be reduced or minimized. Okay, and to preserve the peri-implant tissues and prevent marginal bone loss. As we know, once the implant is placed, within a year, there is up to 0.2 to 0.5 2 of the marginal bone loss is anticipated. So even that can be halted to an extent with the help of alveolar ridge preservation. And we can increase the soft tissue volume and the thickness. As I told, the biotype and the gingival contour can be very well maintained, and even the implant survival rate also increases with the help of alveolar ridge preservation. Now, how it can be done? Well, we got to know why to do and when to do alveolar ridge preservation, and now we have to know how it is done and what is used in alveolar ridge preservation. So in alveolar ridge preservation, we use bone substitutes. It's like your xenograft, your allograft, and alloplast. Okay, and again your soft tissue grafts. For soft tissue graft means your free gingival graft and connective tissue graft, which is taken from the patient's palate. And the barrier membranes. Barrier membranes being the collagen membrane or even your PTFE membrane, titanium membrane. These are. And your platelet concentrations are taken from the patient's own blood, and again there are various types of platelet concentrations. The mostly used ones are the LPRF and the IPRF are mostly used for in the case of AP in combination with the other bone grafts. Okay, that will be same. So now coming to the bone substitutes. As I told, in the bone substitutes, we know that there are autografts. Autografts are the bone grafts which are taken from the patient's own site. So there are various studies done and various case reports and various systematic reviews. To be simple, various cases have been done and they have examined how autographs work when it is used for alveolar ridge preservation or socket preservation. It is effective in reducing the dimensional losses, and the mean buccolingual width loss is only 0.72 mm to 0.85 mm after 6 months. That means once the tooth is extracted and patient's own bone shavings or bone scrapings or extraoral side bones from the being from the ramus or even from the symphysis graft, once it is used, they have observed less than 1 mm of buccolingual width after 6 months. This is coming to the autographs. And again coming to the allograft. Once the allografts have been used, then the amount of new bone formation was observed after 6 months. It is up to 52.7% to 41.5%, being 40 to 50% of the enhanced newborn formation is seen when the allograft are used. And now coming to the xenograft. What are xenografts? Which are taken from the other species. When it is used, there is significant reduced in the alveolar ridge resorption, mostly in the buccolingual width and even in the alveolar ridge height. It is up to 1.18 mm to 1.35 mm in the height. The width and height, there is only less reduction seen when the xenografts have been used. And coming to the alloplast. What is alloplast? The synthetic bone. Okay, the TPA and beta trioxide and all. So when those are used, it has been seen that the newborn formation is seen up to 21 to 66% of the newborn formation is seen. So most of the studies, they have used it in combination. Some use xenograft along with autograft, allograft again with the alloplast, and most of the cases even we go for the autograft. To give a single point answer, always patient's own bone autografts are most effective. Next, again xenografts and alloplast in various ratios they use, 1:3 or 40:60. It depends upon the clinician and the manufacturer instructions in some cases. Okay, now coming to the soft tissue grafts. Soft tissue grafts are there are three types. One is the free gingival graft, which is taken from the palate, and even the subepithelial connective tissue graft, even it is taken from the patient's own palate. But in this, the epithelial layer is not taken, only the connective tissue is taken. And the third one, which is a synthetic one, to be simple, or which is taken from the derived from the other species skin and it has been processed, it is known as acellular dermal matrix. Okay, these three have been extensively used in combination with the bone grafts and even alone for the alveolar ridge preservation. So once when the free gingival graft, it can be used. When it is used, there is excessively preserved socket and the integrity and the volume of the alveolar ridge has been maintained. Okay, when and in the few cases or when in combination with the subepithelial connective tissue graft, it has preserved or there is very less vertical bone loss have been seen. It is up to only 2 mm of vertical bone loss is seen after 6 months in these cases. And now coming to the synthetic one, which being the acellular dermal matrix, when it is used, results show that the buccolingual dimensions of the ridge after 6 months was 5.53, means only 6 mm of bone loss was anticipated after 6 months. Okay. Now coming to the barrier membranes. Okay, barrier membranes are the membranes which are used as a barrier. Okay, once we have done the extraction of the teeth, once the teeth have been extracted, once we place any xenograft, allograft, or any bone graft, it should be covered it should be covered with a barrier. So that is the thing. It's called barrier membranes. There are various type of barrier membranes. As you know, there are resorbable and non-resorbable barrier membranes. For example, non-resorbable are the one which have titanium in it or PTFE membranes, and the resorbable one are the collagen membranes or PLGA or PLA PGA membranes. Okay, these are used along with the bone grafts. It is overlaid on the bone graft to preserve the socket. So again, by various studies or various systematic review and even in my clinical practice, what I got to know, barrier membrane is must. Only we can't just keep a graft and just can't suture it and leave, because then even the graft or the alloplast or whatever bone graft we place, even it gets resolved with the socket bone present in it. So it should be covered with a membrane. So we can, when we use the PTFE membranes or the high density PTFE membranes, it resulted in preservation of the soft tissue, that is the keratinoid tissue, by 3.49 mm, and even the very less horizontal bone loss was seen up to 2 mm. And when the resorbable ones, being the PLA, PGA, or only PLA, when it is used, the new bone was more mineralized and well structured when it is histologically and clinically evaluated in the studies after 6 months. And only the collagen membrane. When the collagen membrane is used, it was observed that only up to 6% of reduction of volumetric it means on the CBCT, when we analyze on the 3D structure, only 12 to 6% of bone was resolved. So these are the various barrier membranes which have to be used in combination with the bone substitutes. And now coming to the platelet concentrates. Platelet concentrates, these are the derived from the patient's own blood. There are various types of platelet concentrates. As you know, it's platelet-rich plasma, PRP, or platelet-rich fibrin, which has more fibrin content. It is known as PRF. And again, in that, again, there are two types: leukocyte-rich PRP or leukocyte-rich PRF, and again, advanced PRF or even titanium PRF. There are various types of PRF which can be prepared from the patient's own blood. It depends on the centrifuge speed and the time. By variation in that, there can be various platelets concentrations can be derived from the patient's own blood, and it can be used for the socket preservation alone, or even in it can be mixed with the bone graft, and it can be even used as a barrier. Okay, when it has been used as a combination or even as a monotherapy with alternate materials like with the bone grafts or even with the other FGG in it, so it has been demonstrated, it was observed that up to 1.5 mm of the vertical resorption was seen after 6 months. And even histological findings, when the sections of various animal studies and some autopsy studies was done, it was seen that it even stimulated new bone formation. So there are various amounts of types of PRF. There's titanium PRF, advanced PRF, HPRF, and all. Which one has shown more results? It is the LPRF and advanced PRF. It has shown more better results when it is used with the autographs or xenograph or even in alone. And now coming to the newer techniques or the newer methods or newer techniques or the cool techniques to say, which have been, there have been various research going on for the alveolar ridge preservation, is injectable bone materials. These are the injectable bone materials, like it's just like a composite which we use. It's still under research. It's easy. Once the tooth has been extracted, it is simple to inject it into the socket, and it solidifies over there and protects the socket. So these are still under research. It is like they are, for example, calcium phosphate cements have been used, and bioactive glasses and nanocomposite hydrogels. Nanocomposite hydrogels have the property of 3D expansion and getting locked into the socket. So these are still under research. We hope it comes into the clinical practice soon. And now we got to know what are the materials to be used and how to use, whether in the combination or to be used in the alone therapy and all. So now we'll know about them, what will happen when we use what. Okay. So again, the current literature means the research which has been done for the alveolar ridge preservation and all. There's a lot of literature done in alveolar ridge preservation. So Even then, there is a dichotomy regarding the efficiency of the bone grafting material in the alveolar ridge preservation, with some of the studies or some of the authors advocating that it benefits in mitigating the resorption, while others say that it may hinder the normal healing or offer negligible results, which means some people are in favor of alveolar preservation. Some people are not in favor. Some say that it is good, it preserves the amount of bone and all. Very few people or very few studies say that it may hinder the socket, the normal healing of an extraction socket and all. So it happens only when patient has any systemic diseases or patient is on any medications or radiation therapy, as we discussed. Okay, alongside there is even lot of debate or lot of confusion going on what to use, whether to go for the autograft or whether to go for the xenograft, or whether to go for the combination of autograft and xenograft, and how much autograft to use and how much xenograft to use. That is the thing, it's debatable, it's a long debate going on. So it again depends upon the case, and even depends on three things: the case and the clinical decision based upon the doctor who is operating, and even the patient, depending upon the case, whether it's anterior or posterior, or whether patient is going for the implant placement after 6 to 8 weeks, or patient is going for delayed implant placement, or patient only wants FPD, or whether the clinician can analyze it, whether if he does he require to preserve it now, or does anything else can be done in that case, or, and even the patient perspective coming to the cost, even the cost and all have to be discussed to the patient. And even we have to explain to the patient, if you're going for the autograph, that from where it will be taken, from the symphysis region or ramus region. So these all factors also play an important role for planning for the alveolar preservation. And now, again, the clinical decision between alveolar ridge preservation and guided bone regeneration is also again a debatable topic. See, guided bone regeneration is a other thing, and alveolar ridge preservation is completely separate. If the steps or the grafts and all membranes which we use might be similar, are 90% similar, but the process or the timing when we do it changes. Okay, when we are hoping it for to preserve the bone then and there itself, followed by extraction, it is known as ARP. When we are doing it after the tooth has been extracted, after some time, after 2 3 months, then it is GPR. Okay, although there are several techniques and materials have been introduced to preserve the alveolar ridge, there is considered heterogeneity with regarding to the barrier membrane and bone graft materials, and the superiority of one technique over other. As I did told you, simply there are no certain guidelines or there are no certain rules. If you want to go for alveolar ridge preservation, you use this, or you use this. There's nothing to do list kind of thing, or nothing, you if you use this you'll get this much amount of alveolar ridge preserved or no. So there's some discussion or some confusion going on. So it's always comes with a clinical decision depending upon the case, what to use, and depending upon the infection and the implant site and the timing of implant placement. The decision regarding to which material to be used, as I told, it is by the operator based upon the various things like amount of keratinized tissue or the patient smile, whether the teeth is in the aesthetic zone, or whether the patient wants implant like in 6 to 8 weeks, or patient can wait for longer time, and depending upon where patient's medical history and all, and overall oral health, like patient's periodontal health status also plays an important role. So these all should be considered for going for alveolar ridge preservation. And now, to conclude, alveolar ridge preservation is a safe and clinically valid method for extraction site management, which with facilitating implant placement and even in the prosthetic driven position. And it has evolved from traditional materials to the innovative materials like PRF and injectable bone repair materials like the newer ones like the hydrogel systems. And the evolution addressed previous challenges such as infection risk and the prolonged healing time and suboptimal bone regeneration. These all can be minimized. So now I want to show you the final flowchart. When can you decide when I have to go for alveolar ridge preservation or when I can go for the direct implant placement. So to decide when you have to go for extraction and all, when you have to go for, when there is not ideal amount of bone present and it requires extraction, implant to, when the implant to be placed, immediate implant, can the immediate implant can be placed in that site depending upon the patient factors and the various clinical factors. If it is everything is good, patient has good amount of bone support and the tooth can be easily extracted, there is no periapical lesion and all, then you can go for the extraction of the teeth and you can go for immediate implant placement. If no, then you can go for the excessive bone grafting is clearly indicated to overcome the resorption. Like patient already came to you with lot of bone resorption, especially with the anterior teeth where there is recession, there is bone loss and even soft tissue loss, and there is severe mobility with the teeth and any periapical lesion. Then you have to go for bone grafting. Bone grafting, for example, in severe hypodontia and retained primary teeth in those cases. And again, if no, these are the not conditions, then extraction can be done. And like as I told, block grafting, so autograft, it can taken from the symphysis region and the ramus, that can be taken and you can do the ARP. And if you don't want to do, there's a lot of infection, you want to just wait and let the periapical lesion heal on its own. So you can wait and then you can plan for the implant placement with the delayed implant placement. Okay, then you can do this. Or once you have done ARP, you have to minimal the time which allows the bone to properly gain its structure and the bone healing to take place. It's only 6 months. Then again you have to go, or minimum 6 to 8 weeks. And the other side, when the implant is not correctly planned or not currently planned, depending upon the all other various factors, then you have to check for the viable future implant site. Well, like for future, now patient is ready for extraction. Now patient doesn't want implant. He told I'll think later, or depending upon the various factors, other conditions of the disease or the periodontal health and all. So by keeping that in the site, again two options arise. Is patient is considering implant for the long term or patient is going for FPD. So if patient is considering implant in long term, then yes, if you have to preserve the structure there, because patient might say, now I'll not get the implant done, I'll get it done after some 3 4 years or 1 2 years or 6 months, I'll just think about it. So then we have to explain to the patient, so and so things happen, if you don't get it done, you have to preserve the bone for the implant, or else again additional bone grafting have to be done while implant placement, so we'll preserve it. So it will be better for you for implant placement or even for the pontic or the FPD, and then you can do the alveolar ridge preservation. Or when no, then only extract without alveolar ridge preservation. And the main important thing when it comes in the anterior region, anterior aesthetic region, then also again check for the facial and the buccal bone thickness, and even for the gummy smile, whether the where is the patient's gingival contour and how much is the lip line. These all should be analyzed before extraction and explain to the patient, and depending upon the condition, then we can go for alveolar ridge preservation in those cases. Because as we know, in the maxillary and the mandibular anterior region, the bone resorption is very severe than the posterior. Once the bone resorption is occurred, then we can't even do direct implant placement. Again, then we have to do any block graft, and again we have to wait for some 4 to 6 months, and again implant placement, again 3 months. So it's a long process. So in those cases, we have to just take a call of alveolar ridge preservation, and then we can do that. And then I'll show you a few cases which have been taken from my colleagues and even from the articles and even my cases. So this is the case where there's where there's a root stump with the teeth. The root stump has been extracted properly, which was RC treated, and later in this case where we can see that the FGG have been taken, patient's own FGG. FGG is placed upon the bone graft. Autogenous bone graft was taken, and then the FGG was placed as a barrier membrane. Here, the FGG has been placed as a barrier membrane, and then after 6 months, we can see how good the gingiva or the gingival contour or the soft tissue and the keratinoid tissue is preserved. So this is what we need while placing implant, the gingival contour or the gingival collar and all. Then implant was placed and followed by the pontic placement. So this you can see the amount of good bone which is achieved by doing alveolar ridge preservation. You can see the before pre-op and the post-op pictures. the good amount of bone and everything is achieved even with the adjacent teeth. Okay. And now coming to the other case, which is the molars, with respect to the 3/6, we can see the 3/6, which was endodontically compromised, which was extracted, followed by the here the xenograft was placed. Once the xenograft was placed, and here the PTFE membrane was placed, and it is sutured. And after 6 months, we can see how good the bone and even the soft tissue was preserved, and then implant placement was done in that case. So even you can see the amount of rich, you can see in the radiographic pictures, the amount of rich the bone and height have we have been achieved in these cases. And this is coming to the anterior region where only we can bone graft is used and the PTFE membrane have been used. And we can see the soft tissue, the biotype, how much it is gained, and even the bone amount which can be anticipated after 6 months. So this is for today. And this is the other case where it is called open grafting, where only the collagen plug have been placed and it has been sutured. In some cases, even collagen plug or even the collagen membrane can be used as a alveolar ridge preservation, but it doesn't give you the much more severe, better results. But some amount of bone resorption can be stopped. That's all for today. Thank you all. If any questions, you're good to ask.
The participants can ask their doubts in the chat box.
Sedu has asked a question like how to choose the bone graft material. It's good. So as I told you, let it be anything. As you know, which graft is superior than on autograft, which is taken from the patient's own body, it is always superior. You can go for autograft if patient is not willing for the autograft to taken from his own, or else while extracting the teeth, you can collect the bone scrapings with the help of bone scraper from the extraction socket itself, and you can from the adjacent bone, you can use those, and you can mix those with the PRF of the blood, and you can make it as a sticky bone and you can even use it. And if patient is not even willing for that, you can go for the xenograft. Even xenografts have been shown very good results for the alveolar ridge preservation, because comparing to the autografts, xenografts have very less and very long duration of resorption rate. Like the xenografts, when they are placed, the resorption of xenograft is very minimal and very slow compared to the autographs. Autographs are very good, but the resorption rate of autographs is more when you compare it to the xenografts. So you can go with the xenografts or autographs, or the mixture of autographs with the platelet concentrates. Okay. Is there any indication for membrane selection? So that's the thing. Membrane selection, as I told you, membrane selection depends upon three factors, like which bone graft you are using, or you have, and even the patient's perspective and the case matters a lot. If it is an anterior case, then you have two options. You can either go with a collagen membrane, which is resorbable, or if there is severe facial bone loss, then you have to go for the PTFE, high density PTFE membrane for the longer duration. So that can be done. Or even in the very minimal cases, there's not much bone resorption, you want to preserve the anterior tooth, you can go for the bone graft, and even you can use a platelet. You can take from the patient's own blood and you can centrifuge it, and you can use a platelet membrane. Even the platelet fibrate PRF can be even used as a membrane over it. Even that has been shown very good results, and even it aids in the healing of the socket in the way. Okay, now coming to the which company graft material. See, as we in our clinical practice, we mostly go with the BioOS, Nova Bone, and Cybograft in few cases, and even for the Perioglass. These are the use. Again, it depends on the granular size. As I told you, xenograft resorbs slowly. So it's better if you go for the xenograft, or you can do combination. As I told you, you can do the patient's own bone scrapings and mix it with amount of xenograft in 1:3 ratio, and then you can use it. So these are all like being it any like the being as in my clinical practice mostly we go with the Noah bone, and even with the bioglass, and even with these, and even in some cases perioglass. Yes, perioglass can be used, but as it is a synthetic species derived bone of the alloglass, it has resorption is much faster when compared to the xenografts and autografts. So, Mithun has asked a question. If we see in a severe bone loss in maxillary anterior with periapical infection, what should be done first? So, in these kind of cases, first extract the teeth, and then we have to look for the whole periapical cyst or periapical. There might be periapical cyst like a radicular cyst or periapical cyst in those regions that should be removed properly, and then place a bone graft, and then wait. You have to at least wait ideally for 3 to 4 months. Then again take the radiograph and check for the periapical any radiolucency, does it resolve? Then you can go for the implant placement. So ideally in periapical lesions, it's very well advised according to clinical various research, and even in my clinical, we wait because the lesion has to resolve first. Then you can go for the implant placement.
Okay, I think we are done with the doubts. So thank you so much, sir, for your time and efforts. Thank you so much for this insightful presentation. Uh, okay, there is one more doubt, I think. Armamentarium required to placement for all these procedures.
See, the armamentarium for average preservation, it comes along with your implant kit. So to collect your bone scrapings, you need a bone scraper. Bone scraper, you might be finding it. There are again two types of bone scraper, which are only for single use, and those cannot be sterilized. So only for single use, only for one patient. Bone scrapers, you can take the patient's own scrapings from the extraction site. And if you want to use PRF and all as a membrane, you need a centrifuge, okay, with at least with Remy company or any other company which is a good one. So you need it. And apart from that, the other armamentarium being bone graft, and that one you will get it from the any manufacturer and all. And you have to use resorbable sutures in these kind of cases. That is the most important thing you should remember. Resorbable sutures have to be used in these kind of cases. There's no much hi-fi armamentarium or anything you require. No need of physiopies or anything. You just require your bone scraper, or else even you can collect your bone with a low cutting micromotor. You can collect it from the any side. That's it. Okay, coming to the book for the implant and implant related material, you can refer Mish. Mish is a very good book. It is in 2 volumes, one for the implant placement and all, and one for the prosthetic driven solutions. You can go through it. You'll find, and or else if you want to know more about bone grafting and all, there is a book on bone grafting materials in periodontics by Dr. Charles Dickens. You can read it. And okay, coming to in clinical setup, whether PRF or centrifugal machine buying is necessary. It's a good question. See, it's all depends on what we see. See, as I told you, PRF and blood concentrates is not only used for alveolar preservation. It is also used for gingival depigmentation. It is also used in various periodontal conditions like even it is used for after FGG for healing of the FGG sites. It is even used for as I told you, while implant placement, and even you can use the IPRF for the for increasing the biotype of the gingiva. It is even used for the wound healing to enhance the wound healing after the extraction. You can just keep a PRF or the IPRF and just suture it. It enhances the wound healing. So these are the things. If you want to use it, it can be even used in the endodontic purposes. IPRF and all have been even used as an endodontic irrigant in few cases, and even it is also used in the perio cases, as I told you, even in the oral surgery cases. So these are the importance of IPRF. There's a lot of scope with the help of PRF and the blood concentrates. So if you want to start using, you can start use it, and there are various. Then we'll come to know where all I can use it. So that is the thing. It,
Okay, I think we are done with the doubts. Thank you so much, sir. Thanks a lot once again for your time and efforts. Okay.
Sure.
So I will now like to invite Dr. Afia Shah to take over the session. She will provide you with an insightful overview of the offerings under the IDA Education Academy and guide you on how you can make the most of these opportunities. Dr. Afia Shah, over to you.
Hello.
Yes, Dr. Afia, you are
Yeah,
audible.
yeah, thank you so much. Hello, everyone. Myself, Dr. Afia Shah. I would just like to share my screen. Just give me a minute. I hope my screen's visible to you all. Hello.
Yes, Doc.
Uh,
But
is
yeah,
yeah,
yeah, your screen is
cool,
visible.
cool.
You can start, Doc.
Okay, hello everyone. Myself, Dr. Afia Shah, and I'm talking on behalf of the IDA's Educational Academy. So, as we all know, that IDA is an independent and a recognized voice of dental professionals in India, and we simply have a vision to improve the oral health and the quality of our people. So, to start with, I would like to give you a brief about what exactly our. It's basically a virtual tour of our head office that is situated in Prabhadevi. And if you would, we would love to host you through if you want to have a physical visit of our head office. Just give me a minute.
Mumbai, the city that never pauses, only prospers. Welcome to the Dr. APJ Abdul Kalam Education, Research and Incubation Center. A warm and inviting space for our patients, designed for comfort and relaxation. Equipped with cutting-edge OPG and CBCT technology, enhancing patient care and treatment precision. Featuring 25 advanced dental chairs dedicated to delivering exceptional care and service to every patient. Tailored for children, with state-of-the-art technology ensuring comfort and safety during treatment. Commitment to the highest hygiene standards through rigorous sterilization protocols, ensuring patient safety at every step. Where expertise meets excellence, nurturing the next generation of dental professionals through transformative lectures. A hub of advanced facilities and realistic demo models, enabling students to sharpen their skills and bridge classroom learning with practical dental experience. Home to modern digital dentistry tools, streamlining the creation of precise prostheses. A collaborative space for research and innovation, where dental professionals unite to transform groundbreaking ideas into the future of oral health. A sophisticated venue for specialty meetings and presentations, fostering collaboration and innovation among dental leaders. A comprehensive digital resource, empowering students and professionals with knowledge at their fingertips. Dedicated to enhancing patient understanding and engagement through informative resources. Environment for faculty to share insights and inspire the next generation of dental practitioners. An exclusive area designed for comfort and networking among distinguished guests and professionals. A vibrant hub where students connect, share experiences, and enjoy delicious food in a lively atmosphere. A prestigious space for seminars and events, promoting continuous learning in the dental field. Together, let's build a healthier, brighter future. For more information, visit our website or follow us on social media.
Hello. I guess that everybody just had a view of how exactly our head office is. So now I would like to just give you a gist about the Indian Dental Association Educational Academy. So it is an initiative of IDA itself, and under this we have three of our top courses, which is CCRP, which is also known as the Comprehensive Clinical Residency Program, and we have our fellowships. So right now, currently, we have two fellowships going on, active fellowships. One being the cranial pain, craniofacial pain, and TMJ disorders, and the other is the sports dentistry. Now we have another section which is known as the dental specialty courses. I hope that I'm audible to all of you.
Yes, ma'am, you can
Yeah,
continue.
yeah, thank you. So basically, the DSC courses include courses that could also known as the weekend courses, because we specially have these courses during the weekend, and they may last for a day or a two. And the topics for the courses, they vary on the type of the topic that is taken up, so you should keep yourself updated so you do not miss any of the topics. That right now we have these topics in line, that is implantology, pediatric dentistry, and all of this. And I guess that is enough for the upcoming courses. Just a brief. Now we would like to go deeper within our top priority program right now, which is our 5 weeks comprehensive clinical residency program. And it is basically a 5 week long general dentistry program, which is curated specifically for you, that is our fresh dental graduates who plan on to opening a clinic, but also you do not want to waste months on observership. And it also aims in refining the clinical skills for those who possibly have had a career gap, or individuals who just wish to have a quick clinical brush up. So it's curated specifically for a clinical brush up. We have multiple mentors which have specializations in masters, like endodontists, prosthodontists, and oral surgeons, who guide you throughout your journey. And what exactly you get through in this program is we have like unlimited cases to provide, as we treat our patients free of cost. So that is one positive point, that our patients are free of cost, so you get unlimited cases and there is no limitations. You can do how many cases you wish to. And we have highly skilled team of mentors, as I just mentioned earlier. And we also extend our help beyond those 5 weeks. That is, we also connect you with successful professionals from our field and help in developing a good clinical practice, that is practice management. And also you get a good hands over your clinical touch. And in cases, we also help with finding jobs through. But these are the things that you might look up to when you are planning to get yourself enrolled for the CCRP program. Now, moving forward to the actual thing. So basically, the only criteria for the CCRP program is, I wouldn't say the criteria, the specific point that you need to keep in mind is that in this program, you learn everything that would be something that you always feared. Maybe not being able to locate canals, or maybe not being able to do the right extractions. You overcome your fears through, which is possibly not something that you come through in the previous 5 years of your dental school, or maybe in the internship you did not get enough patience. So So all of that problems get overcome here. And by the end of the program, we have a convocation day where we celebrate and where we provide you a program completion certificate. That is just, see, you can see the certificate of excellence. And along with that, we have additional 15 certificates of the courses that you attend amidst your periods of 5 weeks. So basically, the 15 additional DSC courses or the workshops that you will be attending during the weekends, you will get certificate for those workshop and courses too. And the best part about it being that it's a bonus. I mean, like, it is inclusive. It was a complimentary certificate of 15. So basically, imagine having one IDA certificate, that is the completion of the CCRB, plus 15 bonus certificates that will boost your resume to another level. Any which ways, now we move forward into one very important aspect that we focus on in today's world is the personalized website. So you may also call it as a digital resume. So the importance of us as dental professional being able to document our cases and put forth what we've actually done, rather than having those books, or maybe we have our albums. We can have all of this in a website. So we, in our CCRP program, we help in building your website through, so you can have a quick digital resume for finding jobs, or maybe just putting up your cases together, your patient testimonies. Everything from scratch is helped through, and it is definitely inclusive of the entire program, as in, like, it is inclusive in the cost itself. And yeah, so moving forth, for any other queries regarding the same, please contact us on the details that I've mentioned. You can take a quick screenshot. Our team would love to assist you through this, and hoping to see you in the IDA's head office. Thank you.
Thank you so much, Dr. Afia, for updating everyone about our upcoming courses. And thank you so much, Dr. Gautam, for the wonderful session today. So for all the participants, I have shared the participation certificate link in the chat box. You can fill in the form to receive the participation certificate link. Along with that, I have also added the YouTube link, so you can always view the session on YouTube. Thank you so much for your time and efforts. Thank you so much, everyone.
Thank you so much.
I am ending the meeting now. I hope everyone has filled in the participation certificate form. Okay, thank you everyone. Good night. Take care.